Greetings, students. This is Dr. Weaver, and I wanted to go ahead and make a couple of voiceovers regarding some GI issues, one being peptic ulcer disease, and I believe the other one is stomach ulcer. I think I will go ahead and just cover peptic ulcer disease for the time being. And then I will make another one, probably be separate from this one, more than likely, given the time right now. And that way you'll have an idea of what you'll understand, rather, the material that we must cover for both disease processes, if you will. So this is complex health. And we will be essentially covering chapters 41 through 43. All right, so let's go ahead and take a look at the objectives here. We have identify assessment findings, management, prevention of complications in complex adult patients with gastrointestinal alterations. And as if you've listened to my orientation to complex health video, you will understand that some of these disease processes you have already covered. I'm not sure to what detail. However, what is most important in this particular course is the complications that these patients will experience. Particularly a hemorrhage. The other objective is review diagnostic tests used to manage gastrointestinal alterations. And the last objective is summarize evidence-based guidelines available in the care of complex adult patients with gastrointestinal alterations. All right. Now, so we will be looking more specifically at peptic ulcer disease. Peptic ulcer disease is a condition that is characterized by essentially erosion of the GI mucosa from the digestive action of hydrochloric acid and pepsin. These are just basically digestive enzymes, acids, if you will, that destroys the mucosa, the tissue that lines the gastrointestinal system. Let me see if I can possibly give you just an example of that. If you can take a look at, and I hope this is presenting, but it's on page 904. If you take a look at figure 41.9, and as you can see, this is the gastric mucosa here, and then you have the erosion because of that, the strong acids from the hydrochloric acid and the pepsin, if you will. And then you have acute ulcers, so it digs down even deeper within the gastric mucosa, right? Even down to near, in this case, the muscularis, the muscle portion of the stomach. And then you have, of course, the chronic ulcer, which goes down even further into the muscularis and close to the serosa. So it just depends on which type of erosion we're talking about. In this case, the erosion can be in the mucosa, and that is here. It can be in the submucosa, which is just beneath the mucosa, and that is in this area. And that's, of course, the acute ulcer. But with the chronic ulcer, it digs down even deeper, or it affects even deeper tissue, the muscles of the stomach. And so here's where we are, the muscularis. So just wanted to give you a visual of how deep these ulcers can go. My apologies. See, so let me go back and present again. All right. All right. Peptic ulcer disease also includes the lower esophagus, of course, of the stomach, but it can also involve the duodenum, which is the first portion of the small intestine. After food leaves the stomach, it goes into the duodenum intestine, or the small intestine. And margin of a jejunal anastomosis after surgical procedures. So sometimes, depending on why, maybe let's say if the patient has what do you call it, Crohn's disease, that might impact the jejunum, which is the small intestine that comes after the duodenum. And sometimes you may have to remove the duodenum and attach the stomach, gastro, to the jejunal small intestine, which is the anastomosis. And of course, sometimes the peptic ulcer disease can involve that particular area. All right. Now, there's a couple of types of peptic ulcer disease, as you saw in the figure that I just demonstrated. Peptic ulcers are classified. They can be acute, they can be chronic, depending on the degree and the duration of mucosal involvement. And as you know, with the chronic involvement, it goes all the way down to the muscularis, into the muscle portion of the stomach. And also gastric and duodenal, according, again, to the location. So again, we're talking about acute and chronic. Now, I just showed you figure 41.9. The acute ulcer is associated with more superficial erosion and minimal inflammation, all right? So just think back or take a look at the image that I showed you, or the figure that I showed you earlier. So it doesn't go down as deep. Now, it is, as far as the acute type of ulcer, it is of more short duration, and it does resolve fairly quickly when the cause can be identified and resolved or removed. All right. Now, a chronic ulcer, which you will note in figure 41.10, is one that is of long duration, eroding through the muscular wall with the formation of fibrous tissue that develops because of the destruction of the stomach's tissue. Now, it is present, as far as the chronic type, it is present continuously for many months or intermittently throughout the person's lifetime. Chronic ulcers are more, actually, they're more common than acute erosions. Now, as far as the etiology or the cause and the pathophysiology, or that which deviates from the normal, peptic ulcers develop only in an acid environment. And of course, as you know, hydrochloric acid, as the name implies, is an acid, and a very strong acid, especially when you look at the pH of this acid. Now, an excessive amount of hydrochloric acid is not necessary for ulcer development. So it doesn't necessarily have to be an excessive amount. Pepsinogen, which is the precursor of pepsin, or the enzyme, it is an enzyme, or before it becomes an enzyme, if you will, it's called pepsinogen before it's changed to pepsin. It does, of course, the pepsinogen changes to pepsin in the presence of hydrochloric acid. So it does need hydrochloric acid, and it also requires a pH between 2 to 3. in order for that conversion to take place. Before pepsinogen can be converted to pepsin, it just requires hydrochloric acid and a fairly low pH. All right. Now, when food or antacids neutralize the stomach acid levels, or drugs block acid secretion, the pH then will increase to about 3.5 or more. All right. Now, at the pH of 3.5 or more, pepsin has little or more proteolytic activity. In other words, it cannot break down protein once it increases to 3.5. Right. Now, the pathophysiology of ulcer development is outlined in figure 41.11. Now, the back diffusion, in other words, hydrochloric acid, it has the tendency of time in this disease process of backing up. So the back diffusion of hydrochloric acid in the gastric mucosa does result in cellular destruction and inflammation. That acid is so powerful, it is able to destroy the cells of the stomach mucosa and causing inflammation, of course. Now, in this particular context, histamine is released from the damaged mucosa. So when the mucosa is damaged, histamine is going to be released. Now, what happens when the histamine is released, it causes vasodilation. It also causes an increase in capillary permeability and further secretion of acid as well as pepsin. All right. Now, if you take a look at figure 4112, it shows the interrelationship between the mucosal blood flow and disruption of the gastric mucosal barrier. All right. Now, several factors does damage the mucosal barrier that we will also explore as we go through this discussion. Right. Now, the factors that damage the mucosal barrier. So one of the major risk factors for peptic ulcer disease is infection. It's caused by an infection, and that infection is known as Helicobacter pylori, or you guys have probably heard of H. pylori. It is a bacteria. It is an infection, and it is the major risk factor. 80% of gastric and 90% of duodenal ulcers are due to this particular bacteria. Now, in the stomach, the bacteria can survive a long time by colonizing the gastric epithelial cells within the mucosal layer. You know, the stomach, the mucosa of the stomach is essentially aligned with gastric epithelial cells. They're just the type of cells that the stomach lining tissue, a layer, is consists of. And of course, this is where this bacteria can reside. Now, the bacteria makes what we call urease, which metabolizes urea producing ammonia, chloride, and of course, other damaging chemicals. Now, this leads to increased gastric secretion and cause tissue damage, leading to peptic ulcer disease. Again, as you know, the hydrochloric acid is a very powerful acid. Usually, I believe the pH is somewhere around 1 point something. That's very powerful. If you can think about the normal blood pH, which is between 7.35 to 7.45, and when we're talking about hydrochloric acid in the stomach, it is in a much more lower pH. And when you have this increase in secretions of this hydrochloric acid, and it makes contact with the stomach's lining or the mucosa, it can certainly lead to more damage, if you will, especially an increased amount. Now, continuing with factors that damage the mucosal barrier, we need to also think about certain medications or medication-induced injury. There's certain medications that patients take, whether it be prescribed or over the counter. In this case, mostly over the counter. That can also destroy the gastric mucosa or the tissue of the stomach's lining. Now, NSAIDs, for example, Aleve, Motrin, is responsible for most of the non-H. pylori ulcers. In other words, we're talking about a drug cause as opposed to the bacterial cause, that bacteria rather being H. pylori. Right. Now, NSAIDs inhibit prostaglandin synthesis. So prostaglandin cannot be synthesized or created. It also increases gastric acid secretion, and it reduces the integrity of the mucosal barrier. All right. So now, as you hear what I'm saying so far, you're probably thinking to yourself, if it impacts the integrity of the mucosal barrier, now we're talking about an ulcer, all right, something that is destroying the mucosal barrier, all right. Remember that barrier protects those structures below it from hydrochloric acid, all right. Now, NSAID use in the presence of H. pylori further increases the risk of peptic ulcer disease. So they both can exist rather at the same time. The bacteria H. pylori may be present along with the patient taking NSAIDs, and that will increase peptic ulcer disease. Now, patients also taking corticosteroids as well as anticoagulants with NSAIDs have an even higher risk for developing a peptic ulcer disease. Now, corticosteroids affect mucosal cell renewal. So the cells cannot, you know how when you think about the cells of the skin, we're constantly shedding and renewing cells. But with the corticosteroids, it can affect the mucosa of the stomach's lining, that's that cell renewal, and which decreases its protective effects. Once you decrease the mucosal lining of the stomach, then you don't have good protection, if you will, especially from acid. Right. Now, again, as we continue with those factors that damage the mucosal barrier, we have to also look at or turn our attention to lifestyle factors. Now, high alcohol intake is associated with acute mucosal lesion. So, alcohol. Uh, as you hear me talk about these different things, also begin to think about some of your health promotion, disease, or health promotion and maintenance, those content areas that you will see on your NCLEX exam. And so you should realize by now that you will be teaching your patients about NSAIDs and how they can cause peptic ulcer disease, and how they should diminish or reduce the amount that they are taking if you allow them to take them at all. Same thing with alcohol. I mean, just the fact that you know that these are some of the factors that contribute to mucosa barrier integrity or compromise, then you know that this will be a part of your teaching at all, and that is a reduction in alcohol intake. Now, alcohol and smoking also stimulates acid secretion. And again, the more acid, the more you're exposing the gastric mucosa to this acid, which can eat into that barrier, if you will. Now, coffee, be that caffeinated or decaffeinated, is also a strong stimulant of gastric acid secretion. And of course, especially with these patients who already have peptic ulcer disease, this will also be a part of your teaching that they should avoid caffeinated, decaffeinated coffee as well. Because again, you're producing more gastric acids, and this is no good when you have when the integrity of the mucosa of the stomach is compromised. Now, smoking and psychologic distress, including be that stress, if it's patients who have depression, it can delay the healing of ulcers once they have developed. All right. So again, in this case, you want to inform your patients to reduce the stress in their lives, the smoking, whether it be from caffeine, alcohol, if you will, because otherwise, then that ulcer, that gastric ulcer, is going to, or duodenum or what have you, it is going to continue for quite some time. Unless a lifestyle change is undertaken. Now, again, with factors that damage the mucosal barrier, as far as the gastric ulcers occur in any part of the stomach. All right. But they most often occur in the antrum part of the stomach. Gastric ulcers are less common than your duodenal ulcers. So the duodenal ulcers occur more frequently. Gastric ulcers are more prevalent in women, of course, as opposed to men. And they occur in those who are over the age of 50 years. Now, gastric ulcers are more likely than duodenal ulcers to cause an obstruction. If you think about it, once the tissues in the stomach begin to change, especially if that tissue is close to the gastric outlet or that portion of the stomach that leads into the duodenum, which is the first part of the small intestine, when that tissue is destroyed by the increase in gastric acid, and it begins to essentially change, then that tissue can actually block that, I believe it's the pyloric portion of the stomach, but it can block that area, and so food is not readily able to transition from the stomach into the duodenum. All right. Now, H. pylori, NSAIDs, and also bile reflux are the main risk factors for this. Sometimes even the bile that comes down from the bile duct from the bile to the bile duct and to the small intestine can also reflux back into the stomach, and it can destroy the tissues of the stomach as well, along with, again, as I mentioned, H. pylori, as well as NSAID. Now, figure 4111, this essentially talks about disruption of the gastric mucosa and the pathophysiologic consequences of back diffusion of acids. These acids are backing up, right, back into the stomach and destroying the tissue even more than what it is. There is a nice explanation with a map. I don't have the page at the moment, but it's on the same page as figure 4111. So take a look at that when you get an opportunity. As far as factors that damage the mucosal barrier, more specifically the duodenal ulcers, Duodenal ulcers, duodenum ulcers, account for about 80% of all peptic ulcer disorders. Now, although many factors are associated with the development of duodenal ulcers, H. pylori or Helicobacter, but let's just call it H. pylori for the time being, is the most common. All right, and also stress-related mucosal disease, or SRMD, is a contributing factor to duodenal ulcers. Now, the development of duodenal ulcers is often associated with a high hydrochloric acid secretion. So the stomach is producing all of this hydrochloric acid that will eventually end up in the duodenum, and it is no good. Now, those at high risk include people with COPD, those with cirrhosis, as well as pancreatitis, hyperparathyroidism, CKD, and also Zollinger-Ellison syndrome, or ZES. Now, ZES, Z-E-S, is a rare condition that is characterized by severe peptic ulcer and hydrochloric acid hypersecretion. Just have more acids that is being secreted. Now, duodenal ulcers tend to occur continuously for weeks or even months, and then they disappear for a period of time, only to, of course, recur months later. All right. As far as the stress-related mucosal disease, it is described later in the chapter in the section on upper GI bleeding, and that you'll find that on page 917. So just take a look at that as you continue to read the required pages. Now let's go ahead and get into some of the clinical manifestations of gastric ulcers, as well as duodenal ulcers. Now, in gastric ulcers, the discomfort is generally high in the epigastrum and occur about 1 to 2 hours after meals. You will note that the pain is described as burning and or gaseous. They have more gas type of pain. If the ulcer has eroded through the gastric mucosa, food tends to worsen the pain. So when you eat, the pain tends to be even worse. All right, because it's irritating all of those nerves that are beneath the gastric mucosa. Now, for some patients, the earliest symptoms are due to a serious complication, such as perforation. All right. And this is when we get into the complex part of this course for this disease process. Because as I mentioned to you, you guys have studied these different disease processes in to a certain extent. And I tend to still go through it with you, because just in case you didn't go into too much detail then, I want to be able to go into those details now, but to add also the complex issues that occur with these disease processes. All right, so when you think about the duodenal ulcers, symptoms occur when gastric acid comes in contact with the ulcers. So these patients, they develop these ulcers in the duodenum. Remember that the first intestines that are reached by the food once it leaves, or that chyme when it leaves the stomach. So it goes into the duodenum. All right, and remember that chyme also consists of that gastric acids. All right, now with meal ingestion, when someone eats, food is present to help buffer the acid. So the acid, remember, the acids will increase in pH when food is present, and so it's less acidic. Still acidic, but just less acidic. Now, symptoms occur generally 2 to 5 hours after a meal. And if you think about that, go back and look at the gastric ulcers and how the pain is 1 to 2 hours after a meal. But remember that that food takes a little more time before it leaves the gastric area and transitions into the duodenum. And therefore, the symptoms for this condition would take a little longer. All right, because the food does have to sit in the stomach for a certain period of time before it transitions to the next phase or into the next body structure, which is the duodenum. The pain is described as burning or cramp-like. It is most often in the mid-epigastric region beneath the xiphoid process. All right. And you guys may have to determine or make a distinction between the two, gastric as well as the gastric and duodenal ulcers. All right. And so in this particular case, and actually both of them can occur as far as gastric and duodenal ulcers. They can occur in the epigastrum. But of course, with the gastric, it's more burning, it's more gaseous. The pain in the duodenum also has burning, but it also has cramp-like. So that's kind of the distinction, if you will. It is most often in the mid-epigastric region beneath the xiphoid process, as I mentioned. And so think about that cramp-like symptom as well. Now, duodenal ulcers can also cause back pain, which is also distinct from gastric ulcers. So you just have to remember some of these differences, if you will. All right. Now, some patients have bloating, they have nausea, vomiting, and also they have early feelings of satiety or fullness. They feel full early. Now, not all patients with ulcers will have pain or discomfort. There are some silent peptic ulcers that are more likely to occur in older adults and those who are taking NSAIDs as well. Of course, if you're taking NSAIDs, the pain might be masked, right? With taking the NSAIDs. And of course, the nerves are not as, they don't work as well in the older adults. And so they may not have that early warning, if you will, from the pain and discomfort as someone who is younger. Hopefully that makes a little sense. All right, so let's talk about some of the diagnostic studies. This is still a part of the assessment. Remember, we talked about the pathophysiology of peptic ulcer disease, and then some of the etiology, of course, and of course, we talked about the assessment as far as the things that you will see in these patients, the things that make one more distinct versus the other. And of course, the diagnostic studies are also a part of the assessment as well. So think about the nursing process. This is, again, we're still in the assessment phase because we want to run a variety of tests, determine if the patient does have peptic ulcer disease. Now, endoscopy is the most accurate procedure to determine the presence and location of an ulcer because you can actually visually and directly see the ulcer, all right? It allows for direct viewing of the gastric and duodenal mucosa. You will be able to see that in figure 41.13. Now, during the endoscopy, tissue specimens are taken to determine if H. pylori is present, and also to rule out stomach cancer, because sometimes it can be stomach cancer as opposed to just an ulcer. And so with the endoscopy procedure, you can actually take a specimen to analyze it under a microscope to determine what it really is. Now, an endoscopy can also assess the degree of ulcer healing after treatment. So it is a procedure that we can employ that will help us to determine if the treatment that we have provided, is it working? All right, and so an endoscopy procedure will allow for that. Now, several non-invasive and invasive tests are available to confirm H. pylori infection. The gold standard, however, for diagnosing H. pylori is a biopsy. You actually have to take a piece of the tissue, particularly of the antral mucosa portion of the stomach, with testing of urease. So this is a rapid urease testing because remember, H. pylori bacteria, it gives off urease. And of course, if you take a biopsy and you analyze it, you can detect if the urease is present. Now, urea is actually a byproduct of the metabolism of H. pylori bacteria. So as the H. pylori bacteria goes through that metabolic process, it produces as a byproduct urea, which can be detected. There are also non-invasive tests to include serology tests. There's also stool tests that can be obtained, and also breath testing. All right. Now, the urea, breath, and stool antigen tests can identify if an infection is active. All right. So those are just some of the different tests, again, that are part of our assessment. Now, there are also laboratory tests, including a CBC, liver enzyme studies, serum amylase, and also stool examination. And this may be done as well. A CBC may show anemia from the ulcer that is bleeding. So as we take a look at these different laboratory tests, let's take a look at what they reveal. So CBC can tell us if anemia, if the patient is bleeding enough, then the H&H or hemoglobin and hematocrit will begin to decrease. Liver enzyme studies help detect any liver problems such as cirrhosis that may complicate ulcer treatment as well. All right. And some of these patients with cirrhosis or liver disorders, they also have peptic ulcer disease. All right. Now, stools are tested for blood. Remember, occult blood. We use the fecal occult test to determine if microscopic blood is present in the stool. You may not be able to see it with the naked eye, but with this particular test, which you all should be able to know how to perform, it essentially turns blue. Once you get the specimen from different portions of the stool and you put it in the two different windows, if you will, in the test itself, and you put the chemical onto it, it turns blue. So just make sure you guys take a look at that. Very important for you to know. A serum amylase evaluates pancreatic function if we suspect posterior duodenal ulcer penetration of the pancreas. Sometimes the ulcer can be situated in a place in the ulcer that is close to the pancreas, and it can erode, get into the pancreas as well. Let me see if I can give you an example of that while we're here. Let's see. I know I saw it, but maybe up here. Maybe not. Just give me a moment. I know I saw it, and I want you to see it as well. Here it is. So you see the ulcer here, right? This is the duodenum here, and this is the ulcer. And look at the close proximity it is to the pancreas. And so that ulcer can eat all the way down into the pancreas. And of course, we want to look at some serum amylase, which is an enzyme that is produced in the pancreas that tells us that this ulcer in the duodenum has also penetrated the pancreas. All right. That's another picture here, the peptic ulcer of the duodenum. So you can see the ulcer located here. All right. Let's see, is that where I want to be? Endoscopy. All right. All right, so I think we're done with this slide. All right. Now let's go ahead and get into some of the conservative care that is provided for these patients. And here again, this is where you really want to listen up, because then you begin to learn how we treat these conditions. These are things that you're not only going to be carrying out as far as interventions, nursing tasks, but these are things that you must also be able to teach our patients. So remember, when we talk about conservative treatment, what we're saying is before we get to the ultimate, which is surgical, we want to try some conservative treatments first, hoping that they would be effective. So treatment begins after diagnostic studies confirm the presence of a peptic ulcer disease. And so take a look at table 41.13. Now, the regimen consists of adequate rest. These patients must rest. They also receive drug therapy. And also we must talk to them about smoking cessation, because remember, it stimulates more gastric acid secretion. And there must also be dietary modification if needed, as well as long-term follow-up care, especially if it's a more chronic type of ulcer. The aim of treatment, of course, is to decrease gastric acidity and also to enhance mucosal defense mechanisms. The mucosa of the stomach protects the underlying structures as our skin protects its underlying structures. And when those areas are compromised, then of course we have problems. All right. Now, aspirin and non-selective NSAIDs must be stopped 4 to 6 weeks. All right. Now, when aspirin must be continued, we provide other medications along with it, because we know that aspirin can affect the gastric mucosa, even cause bleeding. And so we co-administer a PPI like Pepsid. We also may prescribe a H2 receptor blocker, and or we may prescribe misoprostol. May be prescribed. This misoprostol, it can cause abortion, so we have to, before we give this medication, we have to determine if a woman is pregnant before we give it. Patients receiving low-dose aspirin, or we also refer to it as LDA, L as in Larry, D as in David, and A as in Apple, for coronary artery disease or CVD, and a stroke risk, who have a history of ulcer disease, or complications, may need to receive long-term treatment with a PPI. All right. These medications help to reduce the acid in the stomach. And so they may need these medications as well, Pepsid along with the aspirin. Enteric-coated aspirin also decreases local irritation. Of course, when an aspirin is without the enteric-coated portion, it is more the stomach lining is more susceptible to irritation. But when it's coated, then it's less. It is less prone to irritation. All right, because by that time it would probably be into the small intestine. Now, an enteric-coated aspirin, it does decrease that local irritation, but it does not reduce the overall risk for GI bleeding. So these patients, they still can bleed. Now, smoking has irritating effect or an irritating effect on the mucosa, and it delays mucosal healing as well. All right. Now, adequate rest, physical, emotional, both physical, emotional type of rest is important for ulcer healing, if we want the ulcer to heal. And it may also require some changes in the patient's daily routine. And of course, avoiding or restricting alcohol use will enhance or promote healing as well. Right. Now, during the acute exacerbation period without complications, these patients must be made NPO if it's an acute exacerbation. They also may require an NG tube for suction in order to decrease any or to decompress the abdomen, and also to keep those irritating substances from out of the stomach. Again, they need adequate rest and also IV fluid replacement, because if they're NPO, they're not eating, they're not drinking, they need fluid replacement in order for them to not go into an electrolyte, fluid and electrolyte imbalance. Now, here is the next portion here that I'll discuss is when we get into the complications. Remember, we talk about complex health. All that I just talked about to you are things that perhaps you've already read about, and if you didn't, now you've just been educated on those areas with respect to this disease process. But now, what is more germane or relevant to complex health? Sometimes these patients, they do have an acute exacerbation, but they have complications to go along with it. Now, that might consist of hemorrhage, perforation. You know, these patients, the ulcer creates a hole in the duodenum or the stomach. It eats into the tissue that much. I mean, the hydrochloric acid, if you will, and also the obstruction, because the tissue changes to such a degree to where it causes a blockage, if you will. Now, these patients are also NPO. They may require an NG tube for suction, IV PPI, so you can further decrease the acid or the acidity content. They must also be on bed rest. Also, they need IV replacement therapy, maybe or perhaps in the form of lactated ringers or LR. And they may also need blood transfusions, because if they're bleeding, if the ulcer is causing a significant amount of bleeding, it can cause them to become anemic, and they will need blood transfusions. These patients also may need a stomach lavage, and this is when we are basically the patient has an NG tube, and we are flushing the stomach out with sometimes the normal saline is iced, and it causes the blood vessels within the stomach to constrict, causing less bleeding, and it clears up the blood in the stomach. All right, and that's a stomach lavage. Not sure if you all looked at that in fundamentals of nursing. All right. As far as drug therapy is concerned, I want you to take a look at table 41.10. Of course, medications are a key part of the patient's therapy as far as promoting healing. Drug therapy focuses more so on reducing gastric acid secretion and, of course, if needed, to eliminate H. pylori infection. So we have to think about certain antibiotics. Patients with H. pylori infection, they do need treatment with antibiotics and PPI. After the ulcer has healed, many patients, they can stop the PPI therapy. All right. Now, remember, we talked about the conservative management of this disease process. And of course, if that doesn't work, then we have to, progress or graduate to the surgical intervention or therapy. These patients may develop a gastric outlet obstruction, especially if the tissue, the destruction and fibrotic tissue, those changes of the gastric mucosa has taken place and is blocking that area where the pyloric sphincter is located. And so they may need what we call a pyloroplasty or a vagotomy. All right. A vagotomy actually decreases acid secretion, stomach acid secretions as well. There may also be perforation, and so a simple closure with omentum graft may be necessitated. Um, there, there's also ulcer removal or reduction, where the ulcer has to be removed or reduced. And then there's a couple of surgeries. There's the Billroth 1 and 2. So take a look at that in your readings. Or the vagotomy and pyloroplasty, which we pretty much have talked about as well. Now, because ulcers recur, interrupting or stopping therapy can have harmful effects on these or results on these patients. So strict adherence to the prescribed drug regimen is paramount. All right. We have to encourage patients to adhere to the therapy and to continue with follow-up as prescribed. We have to also teach the patient and the caregiver about each drug that is prescribed and why it is ordered. All right, and the expected benefits. And this may help them to adhere to the drug regimen. We also must review what to do if pain and discomfort recur, or there is blood in the vomitus or the vomit or stools of your patients. We must let them know what to do. All right. For the H. pylori, we may have to use antibiotics. So essentially, eradicating H. pylori is an essential part of treating peptic ulcer disease in those patients who test positive for H. pylori bacteria. Now, antibiotic therapy is prescribed concurrently with a PPI for about 14 days. Again, take a look at table 41.14. Now, those who have a penicillin allergy, they can be started on Flagyl or metronidazole instead of amoxicillin in what we call a triple drug regimen. All right. And so we're putting them on an antibiotic, a PPI, as well as an antibiotic. And this is your triple regimen therapy. All right. Now, bismuth can be given alone or as part of a combination capsule, what we call Pylera, and it contains bismuth, tetracycline, and metronidazole. Because of the existence of antibiotic-resistant organisms, a growing number of patients, they do not have H. pylori eradicated, with just a single round of therapy. So they may require multiple rounds of therapy before they can actually eradicate the bacteria. Otherwise, they essentially won't get better. All right. Now, as far as drug therapy, we also want to think about, again, your PPI or proton pump inhibitors, your cytoprotective drug therapy, such as your Carafate, and also other adjunct drugs that we will talk about here as well. Now, PPIs are more effective than your H2 receptor blockers in reducing gastric acid secretion and also promoting ulcer healing. PPIs are used in combination with antibiotics to treat ulcers that are typically caused by H. pylori. Now, as far as the cytoprotective, we have to think about the sucralfate. Sucrovate is used for short-term ulcer treatment. Now, what this does is it does provide mucosal protection for the esophagus, for the stomach, as well as the duodenum. It forms like a coat over the ulcer itself, protecting it from the hydrochloric acid and the food and so forth. Now, this sucrofate, we also call it carafate, does not have acid neutralizing capabilities. So it doesn't neutralize the acid like some of the other ones like PPI or Zantac and so forth. Since it is most effective at low pH, we want to give it at least 60 minutes before or after antacid, or an antacid rather. So we don't want to give it at the same time we're feeding a patient. Give it to them before, maybe an hour before. Or if you give them an antacid, give it to them an hour afterwards. All right. The adverse effects are minimal. Of course, as I said, it is more of a coating. It does bind with certain medications, those medications being Simantadine or Zantac. It also binds with digoxin, warfarin, or Coumadin, phentoin, which is Dilantin, and tetracycline. And it does reduce their bioavailability. So you don't want to give it with these drugs. You want to kind of separate the times that you're giving these drugs so that the other drugs would be more effective for these patients. All right. This is one of the reasons why when we give patients medications, we have to know how medications interact, because if medication makes it makes it with one medication makes another too strong, or we reduce it in some kind of way, then we want to make sure we're giving them at separate times. Now, your H2 receptor blockers and antacids may be used as adjunct therapy to also promote ulcer healing. All right. Now, the antacids increase gastric pH by neutralizing the hydrochloric acid. So it increases it, let's say, from a 1 to maybe a 3. Now, as a result of neutralizing the hydrochloric acid, they reduce the acid content of the chyme. You know, all that the chyme is that the food that is broken down in the stomach before it actually reaches the duodenum. This is especially helpful, especially if you have patients with a duodenal ulcer, and so you're increasing the pH, or you're making it less acidic. Now, some antacids, be that aluminum hydroxide, can bind to bile salts. Thus, it will, of course, decrease the damaging effects of bile on the gastric mucosa, which is what we want. The bile, which is typically used to emulsify or break down fats, can have a destructive impact on the gastric mucosa, and of course, antacids such as aluminum hydroxide can reduce that effect. Now, the misoprostol is a synthetic prostaglandin analog that is prescribed to also prevent gastric ulcers by medications such as your NSAIDs and your aspirins. It has a kind of a protective and some anti-secretory, in other words, against secretion, and anti-secretory effects on the gastric mucosa. So it decreases the secretion of hydrochloric acid. People who need chronic NSAID therapy, for example, those patients who may have osteoarthritis, may benefit from this particular medication, but it does cause diarrhea and abdominal pain, something we have to teach our patients about. It also is teratogenic and must be used with caution in those women of childbearing potential or age. All right. Now, a tricyclic antidepressant such as doxepine or imipramine may also be prescribed for some patients. They may contribute to overall pain relief through their effects on the afferent, not afferent with an E, but afferent with an A, pain fiber transmission. So go back and just think about the pain topics that you you've had in previous courses. So you have the afferent fiber transmission. And so these medications, although they're typically used for antidepressants, they can provide some pain relief for these types of pain. All right. Now, in addition, they have varying degrees of anticholinergic properties, which result in a reduction in acid secretion as well. So the tricyclic antidepressants can reduce acid secretion, thereby leading to better healing of the ulcers, gastric ulcers. Now, anticholinergic drugs are sometimes used for peptic ulcer disease treatment. These drugs are associated with several side effects, be that dry mouth, warm skin, flushing, thirst. These patients can have also tachycardia, dilated pupils, their vision can become blurred, and also urinary retention. And so these are some of the side effects we must teach our patients to watch for if we are prescribing an anticholinergic medication. Now, as far as nutritional therapy, there is no specific diet used to treat peptic ulcer disease. Patients should eat and drink foods and fluids that do not cause any kind of distressing symptoms, of course. Foods that may cause gastric irritation include pepper, maybe carbonated beverages, broth, such as meat extract, and also hot and spicy foods should be avoided. All right. Caffeine-containing beverages and foods can increase symptoms in some patients as well. So we have to teach patients also to avoid alcohol use because it can also delay healing because of its stimulatory effect on secreting hydrochloric acid, if you will. Now, again, as far as getting into some of the complications of peptic ulcer disease, and of course, in the complex health course, this is where we learn about not only ordinary routine treatment of peptic ulcer disease, but what happens when things go awry. So all of these complications are considered emergency situations, and of course, they need surgical interventions. These patients may be bleeding or hemorrhaging. Again, the perforation or gastric outlet obstruction can cause even more problems. Now, hemorrhage or bleeding is the most common complication of peptic ulcer disease. Duodenal ulcers cause more upper GI bleeding episodes than, of course, your gastric ulcers. Now, perforation is considered the most lethal complications of a peptic ulcer disease. Perforation risk is highest with large penetrating duodenal ulcers. So when an ulcer in the small intestine, the duodenum is very large, of course, perforation risk is highest. And you can take a look at that in figure 41.14. Now, the mortality rate associated with perforation of gastric ulcers is higher, of course. Now, the patient with gastric ulcers, they're usually older, and they often have concurrent medical problems. They have other medical issues, comorbidities, if you will, which accounts for the higher mortality rates. They got more than one thing going on, right? Now, with perforation, the ulcer tends to penetrate even the serosal surface. Remember when I showed you that picture and how there were varying degrees of how deep these ulcers went. And of course, none of the ulcers I showed you went or got to the serosal area. However, the ulcers can penetrate that surface. And of course, then we're talking about a perforation at this point. And so spillage or those contents that are in those food contents, the acids, if you will, that are located in the stomach and the duodenum, they will now spill over into the peritoneal cavity, right? The contents entering the peritoneal cavity, it might be air, it could be saliva, you know, you swallow saliva, it goes down into the stomach and so forth, food particles, of course, hydrochloric acid, peptic acid, bacteria, bile, and also pancreatic fluid and enzymes, because you know the pancreas, it produces the enzymes, and those enzymes by way of the pancreatic ducts transitions into the small intestine. And if you have an ulcer that is deep enough in the duodenum, then it can leak right into the peritoneal cavity, causing major issues. Now, the manifestations of perforations are sudden. They have more of a dramatic onset. If the condition is untreated, bacterial peritonitis may occur within a relatively short period of time, perhaps 6 to 12 hours. Now, the patient has sudden, severe upper abdominal pain that quickly spreads throughout the abdomen. There's also pain that radiates to the back and also the shoulder area. Food or antacids will not relieve this patient's pain. It would be refractory to this pain. The abdomen would be more rigid. It will feel like a board as the abdominal muscles try to protect from any further injury. The patient's respirations become also shallow and rapid. I mean, with all that pain in the abdomen, you won't be able to take those deep breaths, or the patient won't be able to take those deep breaths like they normally would be able to. The heart rate is also going to be elevated, and the pulse is going to be weak as well. Bowel sounds are usually absent, and also the patient may experience nausea and vomiting as well. All right. Now, here again, this is what is extremely important for you to pay attention to, because you ask yourself sometimes, well, all right, so we're talking about peptic ulcer disease. What is my job? What must I do? Now that you have a pretty strong foundational understanding of this disease process and all the things that it pretty much entails, what do we do about it? All right. What are the interventions that we are going to implement that we will eventually evaluate? All right. So management of perforations is important. We want to stop the spillage of the gastric or duodenal contents into the peritoneal cavity. We want to also restore blood volume by giving IV fluids, right? And NG2 to decompress the abdomen. And also lactated ringers and albumin solutions. And this will restore the vascular volume that this patient has been depleted, that is depleted due to this particular disorder. So again, we want blood replacement. We want to also place maybe a triple lumen catheter, which I believe is the distal portion of the triple lumen catheter that can analyze or assess the central venous pressure, which you would have, by the time we get to this, you would have learned about that. Basically, it is a portion of the central line or Swan gas catheter that can measure the pressure in the right atrium. And that tells us what the fluid volume is, what the patient's fluid status is. Are they dehydrated? Are they hydrated? Do they have a fluid volume excessive amount of fluids, right? They also need an indwelling catheter, a urinary catheter, because strict intake and output is very important here. If they have a history of heart disease, we must do some ECG monitoring, or again, placement of a pulmonary artery catheter for accurate assessment of left ventricular function. We also want to prescribe broad spectrum antibiotics, or we won't be doing that, but it's something that we will that you can anticipate giving, so we can cover any bacteria that could cause this patient an infection until we can possibly get what do you call it? Get a sample, determine what we know it is, and it will likely be maybe E. coli or some bacteria. So a broad spectrum antibiotic would be effective against that organism. Larger perforations are more than likely going to need immediate surgical closure. It might be an open or laparoscopic repair, depending on the location of the ulcer, and of course the preference of the healthcare provider. The procedure involving the least risk to the patient is simple oversewing of the perforation, and of course reinforcement of the area with a graft of the omentum. And so that is your surgical intervention. All right. As far as gastric outlet obstruction, all right, both acute and chronic peptic ulcer disease can lead to a gastric outlet obstruction. Obstruction in the stomach and also duodenum is the result of what? Edema. There's inflammation, pylorospasms. In other words, the pyloric sphincter, that area, it begins to just spasm, right, because of all this inflammation and irritation. There's also fibrous scar tissue formation, and all of these can cause an obstruction to the outflow of food into the duodenum once it's broken down. Now, with obstruction, the patient reports discomfort or pain that is worse towards the end of the day as the stomach fills up and it also dilates. All right. Now, belching or self-induced vomiting may provide some relief for these patients. Vomiting is common and it can be projectile. All right, not your regular vomiting, but go across the room type of projectile. Constipation occurs because of dehydration. You don't have enough fluids in the intestine, and so the stool become more dry and hence leads to constipation. There's also a decrease in diet intake. These patients are anorexic. They just don't feel like eating. Over time, dilation of the stomach and visible swelling, and there's also a visible swelling in the upper abdomen may occur as well. Again, it might be visible. Now, the aim of therapy for obstruction is to decompress the stomach, also to correct any existing fluid and electrolyte imbalances, and also improve the patient's general state of health. All right. Now, an NG tube is typically used as described previously with continuous decompression of the stomach over several days. The ulcer can begin healing, and also the inflammation and the edema will at some point subside or something that we're looking for. Pain relief results from decompression. When you can decompress the stomach, the patient can have less pain as well. All right. Now, IV fluids and electrolytes are replaced according to the, depending on how dehydrated the patient is, how much vomiting they're having, and also based on the laboratory values, the electrolytes, what they're showing. All right. A PPI or an H2 receptor blocker is used if the if the obstruction is due to an active ulcer. If the patient is actually having an ulcer, then these drugs are essential. Also, there's a procedure called a balloon dilation, can also open the pyloric obstruction. So if the obstruction is around that pyloric sphincter, you can put a device in that area and you can inflate the balloon and it'll dilate the pyloric, and of course then food is able to transition from the stomach to the duodenum. Also, surgery may be needed to remove scar tissue. which of course scar tissue can develop either from surgery or can develop because of all the destruction from the hydrochloric acid and those other chemicals, if you will. All right. I think I'm going to go ahead and stop right here. I do have a stomach cancer to go over, which I'll probably do that later today, but I want to stop right here. It is pretty late, believe it or not. I won't tell you how late it is. But this should be enough information to give you a pretty good understanding of this disease process and its complications. And so I will get back with you. And thank you for watching this video. Hopefully it is helpful to you.